And thank you everyone for coming today. So as mentioned, the topic is detection of chronic kidney disease of unknown etiology in Florida. So the fundamental hypothesis underlying our study is that chronic kidney disease of unknown etiology, also called uncertain etiology or undetermined etiology, exists among agricultural workers in Florida. And so if you don't know what CKDu is yet or why we might expect it's in Florida, don't worry, I'm going to go over that. Starting with the latter, we know that CKDu exists in agricultural workers in hot climates elsewhere around the world. It was originally described in workers in Central America, and thus the condition was also known as Mesoamerican nephropathy. The primary etiological hypothesis is repetitive acute kidney injury due to dehydration. So the thinking is that these workers get hot and dehydrated severely, and that causes some acute tubular necrosis, maybe leading to acute kidney injury. And as they have that repeatedly over their working years, it leads to a chronic condition. And then research has documented that agricultural workers in Florida have had acute kidney injury during their working time. So it stands to reason then that maybe if they get that repetitively, they may have chronic kidney disease of unknown etiology. So the goals of our project are to detect any CKDu in Florida, describe it, and look for associations with occupation. Enhance the surveillance infrastructure we're going to use to find CKDu to lower the detection threshold as low as we can to make sure we detect what CKDu may exist. And then we can do geographical analysis to determine the distribution of CKDu around the state. And, using some techniques of people in our university have developed, we can adjust, as I'll explain, One Florida is a healthcare-based surveillance infrastructure. So extrapolating to the entire population has to be done very carefully and with great, sort of circumspection. So we will do that. So what is CKDu? It's defined as fulfilling KDIGO criteria, which I'll explain what KDIGO is in a minute. In the absence of a recognized etiology or risk factor for CKD. So KDIGO criteria are definitional criteria for chronic kidney disease and staging chronic kidney disease. KDIGO stands for Kidney Disease Improving Global Outcomes, and it describes itself as the, with emphasis, global nonprofit organization developing and implementing evidence-based clinical practice guidelines in kidney disease. The clinical presentation of CKDu is a progressive reduction in renal or kidney function in individuals who are otherwise almost entirely asymptomatic. When they do have symptoms, they generally report increasing muscle weakness that they're unable to attribute the cause. High uric acid levels in the urine and low potassium levels in the blood are common clinical features. And typically it's accompanied by high loss of electrolytes through the urine. Other clinical findings on renal ultrasound, usually you just see small echogenic kidneys with no typical specific structural patterns that indicate particular pathology. On biopsy, you usually see what's known as tubulo-interstitial involvement, which just means they have chronic kidney disease, and you can't tell it apart from other etiologies of chronic kidney disease. The epidemiology of CKDu, again, it primarily was discovered and endemic and found in Central America. El Salvador has the highest mortality rate for CKD of all causes, in the world at 51 deaths per 100,000 people. It primarily affects their men aged 20 to 60 years old, with a male to female ratio of 2 to 1 in the range of 2 to 1 to 5 to 1. The prevalence of CKD in farming communities in El Salvador is 15 to 21%, and less than 50% are due to diabetes or other recognized etiologies and risk factors. So looks like, if you assume that 50% of all CKD is CKDu in El Salvador, then 7.5 to 10.5% of the population has CKDu. Elsewhere in Central America, Nicaragua has a higher prevalence of chronic kidney disease among banana and sugarcane plantation workers than among the general population. In Costa Rica, CKD reached epidemic proportions among male sugarcane workers. And in Guatemala, the highest prevalence of chronic kidney disease in Guatemala is along the coast, which I'll use my pointer here. You can see Guatemala along the coast, El Salvador, coastal regions in Nicaragua and Costa Rica. The Pacific coast particularly is the region where Mesoamerican nephropathy exists in high prevalence. It's been found elsewhere around the world, however, not just Central America. So in Sri Lanka, CKDu is literally the most significant public health issue in the north central province of Sri Lanka. In India, the Udanam province has CKDu prevalence of 16 to 24% of the population. And it's also been found in Mexico, Egypt, and Tunisia. The potential etiology, as I alluded to earlier, the favored hypothesis is recurrent episodes of acute kidney injury caused by severe dehydration or volume depletion while working in hot climate zones. However, there are other theories as well. Exposure to pesticides such as glyphosate and heavy metals, consumption of non-steroidal anti-inflammatory drugs, antibiotics, and possibly other drugs that injure the kidneys. And even endemic infections have been posited as a cause of CKDu, like leptospirosis. Nothing has been conclusively shown to be the etiology, however. So now I want to shift gears and talk about the surveillance infrastructure we're going to use to attempt to detect CKDu in Florida. And it's based on the One Florida Plus Clinical Research Consortium. So the One Florida Plus Clinical Research Consortium is an enduring infrastructure and capacity for identifying study populations, or cohort discovery, as we say, comparative effectiveness research, so comparing the relative effectiveness of treatments, drugs, and devices. We also do clinical trials, especially pragmatic clinical trials. And then we work with the network to translate findings from the research into practice. And the partnership of One Florida involves people, most importantly, clinicians, health systems, payers, and industry. Our key partners are our healthcare system partners when it comes to the data infrastructure and the carrying out clinical trials infrastructure. So we have 10 health systems around the state, plus Emory University in Atlanta and University of Alabama at Birmingham in Birmingham, Alabama. You can see we have UF Health, Florida State University, University of Miami and its health system called UHealth, Orlando Regional, Advent Health, Tallahassee Memorial Healthcare, Tampa General. Bond Community Health Center is a federally qualified health center in Tallahassee that supplements the Tallahassee Memorial Healthcare coverage in that city. We have Nicholas Children's Hospital, Community Health IT, University of South Florida, and USF Health in the Tampa region. And as I mentioned before, Emory and UAB. Capital Health Plan's a collaborator. They provide additional data on Bond and Tallahassee Memorial patients. The Florida Agency for Healthcare Administration provides statewide Medicaid data, and we work with the Florida Department of Health on various projects and have had discussions with them about other statewide data sets. And the idea is to do, we can also use the infrastructure for real world data studies to generate real world evidence. As defined by the Food and Drug Administration, real world data are data relating to patient health status and or the delivery of healthcare routinely collected from a variety of sources. So we especially include electronic health record and administrative claims data under that banner. And we also want to include outcomes of importance to patients and work on interventions that are easily translated into clinical practice, so they'll have widespread adoption and have an impact on the health of the public. So the data trust of One Florida Plus, again, has electronic health record data from the 12 partners, including the 10 around the state. Our funding agency, the Patient-Centered Outcomes Research Institute, has a call for proposals out currently to add new partners. So we continue to add partners over time, and we expect to continue to do so. And as I'll explain later, part of this project involves potentially adding new partners to the One Florida network and including their electronic health record data in the data trust. I mentioned we've got statewide claims data for Medicaid for Florida. We also have claims data from Capital Health Plan. We've got linked mother-baby data from the state and tumor registry data from several partners. All patients can be re-identified, as I'll explain the process for that, I think on the next slide, so that they can be contacted by their local health system. We won't contact anybody's patients without their permission and direct involvement to enroll them in studies. And then below is a list of a lot of the infrastructure funding that has helped to create the data trust and build the One Florida Consortium in general. So the data trust, to go into a few more details about it, this diagram just shows, as it builds itself automatically, how the data flows into the data trust from the left. So we have electronic health record data, patient-reported outcomes, linked mother-baby data, geocoded data, Medicaid data. We also have commercial source of death data to improve our capture of mortality as an outcome. And that all comes into the data trust. Then we allow people to query the data trust in a de-identified manner. And that enables them to submit a study protocol and proposal to the executive committee. The executive committee can approve a protocol. If the protocol does allow re-identification of patients, then each site has honest brokers, and we can provide the query results back to the honest brokers with their linkage codes. And they can then translate their linkage code back. They are the only ones that have this mapping back to their medical record number and provide that to a site PI who can contact the patient. Note that we do deduplicate records across sources using a technology called privacy preserving record linkage. I'm not going to go into detail on that, but just know that we can track patients across electronic health record sites and Medicaid claims and Capital Health Plan claims. So the data we have to present from 2012, so this is cumulative, this is not a snapshot, so we're not claiming we have data on all 20 million Floridians, we don't. But we do have data on 20 million people over time who received healthcare in Florida, Alabama, and Georgia. And that totals to nearly a billion encounters, 2 billion diagnoses, 1.25 billion clinical laboratory test results, 730 million claims, 2.25 billion procedures. From the claims data, we have pharmacy claims data, so it's 400 million dispensed medications and 1.75 million clinical findings like vital signs and pulse oximetry results. All these data we harmonize to one common data model. We're required for our PCORI funding to harmonize our data to the PCORNet common data model. And the common data model is currently in version 6.0. 6.1 was just approved and will be implemented later this calendar year. Each rectangle here is a table in the common data model, and the primary key and any foreign keys and other combination keys are shown in this table. It doesn't show every field in the table, but it just shows if you understand relational database architecture, it just shows primary and foreign keys. So with that background, the plan for our study is as follows. We want to develop a case definition or detection algorithm for CKDu. So we want a case detection algorithm that we can apply to the data, and I'll explain more about that in the coming slides. And then we can apply that definition to the One Florida data trust data to identify all the patients around the state who we believe with strong validity have CKDu. And then we can analyze that cohort around the state. We can, again, with a lot of caution and circumspection, extrapolate to a statewide prevalence and incidence. But also we can do some geographical analysis to identify areas of higher prevalence and incidence versus other regions in the state. And we also, as part of the project, are going to enhance the surveillance infrastructure, the data trust, to improve our chances of detecting CKDu, and I'll talk about that more as well. So with respect to the case definition / case detection algorithm, there are no specific, one reason we need to do this is there are no specific diagnostic codes for CKDu versus overall CKD. And even then, diagnostic codes alone are bad at detecting CKD, as I'll explain in a minute. So we need to build an algorithm that detects chronic kidney disease and rules out those, quote, recognized etiologies and risk factors in the formal definition of CKDu. As you'll recall, it's the definition that talks about meeting the KDIGO criteria in the absence of recognized etiologies and risk factors, such as diabetes and hypertension. So another name for these case detection algorithms is a computable phenotype. So the field of reuse of EHR data for research broadly has coined the term computable phenotype or electronic phenotype. And it just means it's a decision algorithm. And the algorithm takes multiple types of data as input. So it'll take diagnoses, prescriptions, procedures, clinical laboratory tests, vital signs, multiple of the tables in the common data model. It'll use those data all together to output a yes or a not yes answer. Does the patient have condition X? Note that this is a not yes answer and not a no answer. So if the algorithm does not say yes, the patient has CKDu, that does not mean the algorithm is definitively declaring no, the patient does not have CKDu. It's just silent. It's just, I don't know almost. And the work in this field involves validating and measuring the performance characteristics of these algorithms, typically in terms of things like positive predictive value, precision and recall. So there does exist, and as I'll explain, one of the results of our work to date is we've done an extensive review of computable phenotypes for chronic kidney disease, and we hit on a really good one, as I'll explain. And it has two parts. It has one part that says, yes, the patient has chronic kidney disease, and another part that says, yes, this patient, by contrast, is a healthy control patient. And so that's going to identify two cohorts, a cohort of patients that definitively or with high probability have CKD, and a cohort of patients with high probability who are healthy controls without CKD. And in between those two is probably another cohort that neither part of the algorithm makes a definitive declaration one way or the other. This algorithm was validated through 451 chart reviews at 3 academic medical centers. I believe it was Columbia, Vanderbilt, and I'm blanking on the third one, I think Geisinger Health System. And an independent case control validation showed a positive predictive value of the algorithm for chronic kidney disease of 95% and an overall sensitivity of 87%. And the logic built into the algorithm combines aspects of various things, such as the National Kidney Foundation's KDOQI guidelines, the KDIGO clinical practice guideline I mentioned earlier, as well as domain expert knowledge in nephrology. And the reference for a publication about this phenotype is off to the bottom right of this slide. This is a figure from the paper. It's too small for you to read, but it just shows you that it's a fairly extensive diagram, a fairly extensive algorithm with multiple steps and yes/no boxes and various stages of pre-filtering, what they call G staging and A staging, where I think G staging is based on glomerular filtration rate and A staging is based on albuminuria. So a few more key points about this computable phenotype. The author subsequently applied it to data on over 1 million patients. And when they did that, they found that 80% of the cases of CKD detected by the algorithm did not have an ICD-10-CM billing code for chronic kidney disease. So if you just looked at ICD-10 codes, your sensitivity for CKD is only 20%. So this is a stark illustration of the high unreliability of our quote unquote diagnosis coding system in the United States, and is, sort of post hoc a strong motivator for creating a computable phenotype in the first place, and certainly a strong caution to us that we need to do a similar approach for this work. The algorithm also does well in identifying the correct stage of the patient. I don't reproduce here the positive predictive value and sensitivity results for stage by stage, but overall they're very good, and there's a table in the paper. If you're interested, you can go look at that. And then I mentioned there's a healthy control part. The healthy control part of the algorithm has a positive predictive value of 97%. So also very good performance to say that somebody does not have chronic kidney disease. And the good news is we don't need to modify that part. We can use that part as is. So we're going to start with this computable phenotype and progressively modify it to exclude recognized etiologies and risk factors. So obviously, some of the two biggest causes of chronic kidney disease in the United States tend to be diabetes mellitus and hypertension, but there's other causes like polycystic kidney disease and Goodpasture syndrome. And then we're going to validate our algorithm just like the authors did theirs. We'll validate it using clinical notes from UF Health. At all of UF Health's campuses, not just Gainesville, so we'll also take into account patients at our Jacksonville and Central Florida campuses. And usually computable phenotype development's not one and done. You have to, you do some chart reviews, you get some performance metrics. As you do the chart reviews, you are inspired for ideas about how to improve it, and your performance metrics aren't always where you want them. So you modify the algorithm and try again and do the chart reviews over again, and you iteratively refine the phenotype till you get it to a level where you've sort of reached a local optimum of performance. And then, we'll know through that process what its performance characteristics are. Its precision, recall, harmonic mean of precision and recall called F1, and positive predictive value. So then we will apply the computable phenotype to the One Florida Data Trust, the entire data set, which requires we implement the computable phenotype as software. Fortunately, the computable phenotype I mentioned earlier has an open source implementation. We might leverage and reuse a lot of that software, at least figure out any questions we have about the overall algorithm will be answered where the rubber meets the road, so to speak. And then we can execute the algorithm against the entire data trust to get a total of CKDu in the state, breakdowns by demographics, age, race, ethnicity, and gender. We can break it down by geography, major administrative units like zip codes, or technically what's called zip code tabulation areas in counties. We do have ZIP9 through a lot of the networks. We can actually get it down to census tracts for most patients in the network. And we also want to break it down by time, right? So how many new CKDu patients are there by year, by month, and so on. And of course, we want to make our computable phenotype available to the community to reuse for their own research. And there's a resource for that called PHEKB, PHEKB. And so the computable phenotype we're going to begin with to create ours is out there on PHEKB as our computable phenotypes for things like diabetes mellitus. So we just want to make our own contribution to that resource for future researchers to be able to use. And then again, once we have the cohort of patients, we can conduct more detailed analyses. We do need to adjust, and again, our quantitative researchers have some excellent methods that they've published on how you adapt the coverage we have in one Florida and extrapolating those to overall prevalence and incidence. And then we can do geographical analysis as well, so-called hotspot analysis, looking for regions of high prevalence of CKDu, using advanced methods for spatial data analysis that our team has expertise in. And then we can look at any hotspots and say, hey, are these in or near regions of Florida that have higher agricultural activity? What kinds of agricultural activity in particular? And then again, just adjustments to estimate the incidence and prevalence. We also think we can take a first stab, at least, at addressing the pesticide hypothesis. The Southeast Coastal Center for Agricultural Health and Safety has previously estimated the extent of usage of various pesticides around Florida and by geography. So we can use these estimates to additionally map out and analyze CKDu hotspots relative to areas of high usage of various pesticides to see if there's any spatial correlations there. And there's the reference for the prior work done by Greg Glass and his colleagues. I also mentioned we want to enhance the surveillance infrastructure so that we can improve our chances of detecting CKDu. So that means adding data to the data trust. So we plan to add up to 4 or 5 community and migrant health centers around the state to One Florida Plus, which means we would incorporate their full complement of structured electronic health record data into the data trust, all those tables of the pCornet common data model I mentioned earlier. And we're targeting initially in high priority centers with higher patient volumes and that are closer to large agricultural operations in the state. And then we also want to get to the extent that it's available, occupation data. And so we surveyed all our existing One Florida partners about the extent to which they collect occupation as a data element. Sadly, it's rarely collected, but what is available, we have requested and are going to analyze. Some community and migrant health centers that we've worked with and reached out to in preliminary work running up to the proposal and early in the project, they report having more occupation data than the large health systems that are part of One Florida. So there's still some reason for optimism that we'll find a good complement of occupation data. And the reason that would be really helpful is if we can, well, before I get there, we, again, like I mentioned, we did find one partner who has occupation data and promise to provide all the occupation data they have, but it's only for 1% or less of their patients. And again, we'll get it from as much occupation data as the community and migrant health centers have. But if we can identify agricultural workers directly from these data, then we can, look directly at how many patients that we know are agricultural workers have CKDu. So with that as, sort of the overall background of the study, some plans and a little bit of a couple spoilers of results so far, I'll now just talk specifically about what we've done so far in this project and where we head next. So today, again, we identified the good chronic kidney disease computable phenotype we can use as a starting point. And we didn't just say, oh, that one looks good. We did an extensive literature review and survey of chronic kidney disease computable phenotypes. And, the literature is, there's a lot of literature on how people find chronic kidney disease in electronic health record data sets. And we really did narrow down their characteristics and identify the most promising candidate, and it's heads and shoulders the most promising candidate. And so we've started our review of how we're going to identify exclusions. So how are we going to determine diabetes mellitus and hypertension and polycystic kidney disease? Because we want to exclude those etiologies, recognized etiologies and risk factors. And we started reviewing the author's open source implementation to see how much work it's going to be to adapt it to the data we have in the data trust. We've initiated conversations with multiple community and migrant health centers. So my apologies to my study team if I've got the number wrong here, but I believe we've had conversations with 3 or 4. Additional outreach ongoing to 7 more as we speak. Again, we're requesting occupation data from existing and prospective new One Florida partners. And it was also suggested to us that the H-2A visa process could be a potential place for finding data that can help us identify the health status of migrant health workers. So as I understand it, the H-2A visa process has almost entirely replaced the traditional processes for migrants to the United States to work in agricultural operations. And so I'll talk more about that in a minute. But first, I just want to show, the power of the data just to start getting some sense of the landscape. So at UF Health, we have a tool called I2B2. So this is a screen print from I2B2 that I did recently, where I queried here for patients that have chronic kidney disease by diagnosis codes. Again, recognizing that I'm sort of, despite my disdain for the billing coding system, it is all we have at times. And we're going to do much better than this, but this is just a preliminary, back of the envelope, like I said. So all patients with a chronic kidney disease diagnosis code that have no diabetes diagnosis codes and that have no hypertensive diagnosis codes and that have no renal artery stenosis diagnosis codes and that have no cystic kidney disease and that have no SLE and that have no glomerular disease. And that narrows it down from about, I think the number is actually, about 44,000 to about 6,500 patients when we exclude many known causes, and I may have missed some. Compared to all CKD patients, this quasi-CKDu cohort has higher percentages of people younger than 65 years old who are white and who are other race. Other is just a wastebasket category where they identify as a category that's not in the OMB list. And so 44% are younger than 65 versus 34% of all CKD patients. So it seems like we're already starting to identify the demographic cohort that looks like CKDu as described in the literature, although, lots of hand waving and caveats with this result. Coming back to the H2A visa process, so the reason it was suggested to us as a potential point of data source to get information on the health status of agricultural workers is that H2A workers are required to get a physical and health screening performed prior to getting their visa. However, that health screening is done in Mexico. What the U.S. immigration authorities review is just the results, health screen or a health certificate. And it's really just to make sure that their vaccines are current. And all the records of the health screening are maintained in Mexico. So sadly, this turns out not to be a promising source of supplemental data. I think we may have one or two threads to pull on with respect to H2A visas, but overall, so far, it's not looking like anything that's going to help. So to summarize, before I take questions, this project is about intensively searching for chronic kidney disease of unknown etiology in the state of Florida, improving our ability to find it by enhancing our surveillance infrastructure and collecting occupation data. And any CKDu we do find, we will characterize demographically and geographically, geographic distribution, and also time, looking if we can at incidence over time. And we've made significant progress on building some of the key infrastructural pieces we need, especially the computable phenotype, and starting the conversations with the health centers to get their electronic health record data. We obviously have a long way to go to the summit, so to speak. But we're optimistic, and so far things are going very well. Just like to acknowledge the funding for this project from the SCCAHS and all the people involved in the project who have helped us get it underway, and the study team. And my apologies for the people I'm sure to have left out. We greatly appreciate everyone's advice and work on this project. So with that, I'll stop and take questions.
Great. Well, thank you so much, Dr. Hogan, for that wonderful presentation. Yeah, as Dr. Hogan said, it's time for questions and comments. You can put those into the Q&A. You can put them into the chat. We'll be taking a look at those. And so we'll give everyone just a couple of minutes to think through some of your thoughts and put in any questions. But yeah.
Perhaps, go ahead, Philip.
No, well, I was going to say I have a couple questions, but if you wanted to share something while we're waiting.
No, go ahead. Why don't you go ahead with your question?
Okay. Yeah, and I guess my first question is, and I will. Well, anyway, so you mentioned at the beginning the prevalence of CKDu in places like El Salvador, Sri Lanka, and how much it was recognized and how much of the population, especially the agricultural population, had been determined as having CKDu. But here in the US, especially in parts of Florida, not so much. So I guess I'm just kind of wondering what's the difference that you would say? Is it just the prevalence is so much higher in these more developing nations? Are agricultural practices so much different, you think? Or is it something to do with the way that we are monitoring our health system here in the US?
Yeah, so great question. So the first aspect of that answer is that our climate isn't quite as hot, or it's actually really significantly less hot than Central America. So it could be the relative, frequency with which workers get severe dehydration that leads to acute kidney injury is less. So that's one. The other is that, this is just an etiological hypothesis, and there are equally hot climates to Central America and Sri Lanka and those portions of India that I mentioned, that don't have high incidences of chronic kidney disease, let alone chronic kidney disease of unknown etiology. So there are some counterexamples to the primary hypothesis. It could be a combination of factors, either local to the regions where it's occurring, or there could be genetic factors involved. So the review article that I was basing a lot of my information on does address some genetic factors, although there doesn't seem, it just talks about susceptibility to chronic kidney disease as a reasonably heritable trait. So all those factors seem to come into play. There's been discussion among the experts that I don't fully understand myself about whether burning is used. And there's like there's also mechanical harvesting of sugarcane crops, and whether you use mechanical harvesting versus fully manual labor might be an aspect of it as well.
Great, thank you for that. Yeah, a lot of complexities here. So there were a couple questions that just came in, and I can read them and then we can address them. Have you all explored the option of mandating all One Florida participating hospitals to require occupation as a field for their medical records? I learned that there is an option in the, and I may be saying this wrong, EPIC EHR system to include this.
Yeah, so we've had discussion with our One Florida partners about occupation data and plans to collect it, and what we might be able to do to incentivize them. Participation in One Florida is voluntary, and there are contractual mandates for the PCORI funding that comes through. But unless they're required to do it for PCORI funding, they often are unwilling to exceed those requirements without additional funding. It is a big lift to collect the data organizationally and from a process perspective, so I don't want to minimize how hard it is. But the fact that the field's already there and the capability is in the EHR is great. A lot of times what we do is we'll start a particular innovation from an informatics perspective at UF Health. And then once we demonstrate it and demonstrate how to do it and iron out all the bugs and solve all the gotchas we didn't expect, then we take it out and roll it out to other partners. So we would like to see it. It's really sad the government missed a huge opportunity with meaningful use to require it as a demographic variable, like it required preferred language as a demographic variable. I can tell you there was almost no collection of preferred language as a structured data element in EHRs prior to meaningful use, but because it was a required demographic variable for meaningful use, now it's routinely collected. So there might be a government policy aspect to this that would benefit everybody nationally as well.
Great, thank you. And another question, do you know which pesticides, glyphosate and others, that are primary epidemiologic interest, that are of primary epidemiologic interest?
So I'm not the expert on this per se, but glyphosate is the main one. Yeah. Others I'm not quite as sure about. With respect to heavy metals, I think they were just looking at all heavy metals that are known to be nephrotoxic.
And once again, just want to remind everyone, if you have any questions, you can put them in the chat or the Q&A. I've got both of those open, so we're monitoring those. We have just a few more minutes left. We'll close up if all the questions have come in.
Yeah,
I'll go ahead.
I just want to mention about One Florida. You know, it is a general infrastructure for research studies. So if folks are interested in, you know, put in a small plug. If folks are interested in using One Florida for studies, you know, there is a front door intake process. The burden is minimal. We do have an office of data science that will consult with researchers on understanding the data and what you can do with it. There is an executive committee that governs One Florida. Each partner that I listed has one voting member, and the community and migrant health centers, if we, as we add those as part of this project, they'll also have a voting member on the executive committee. And, you know, they do approve studies. We rarely reject studies. Usually there's something, usually the reason we turn down studies is because it turns out that the data aren't able to answer their question. We're missing a key data element. So
Great. I'll close with one more broad question, and then we can end the webinar. But what are your next steps for the project? I know it sounds like there's been a lot of groundwork, and I know for the Southeastern Coastal Center for Ag Health and Safety, we're in the second renewal process that we just started. So what are the next steps that you have lined up?
Sure. The immediate next steps are to finish building and validating our computable phenotypes. Like I mentioned, we're starting to develop criteria for excluding diabetes mellitus as an etiology for CKD. So we need to use more than diagnosis codes. So we're looking at clinical laboratory tests. So if patients have a history of a high hemoglobin A1C, a higher, you know, a really high random glucose, a moderately high fasting glucose, any usage consistently and chronically of certain, you know, diabetic medications would all be indicators of diabetes that we would then exclude those patients as having CKDu. Similarly with hypertension, we supplement diagnosis codes with actual blood pressure measurements. And you have to be careful with a lot of antihypertensive drugs because they do have indications other than hypertension frequently. A lot of them are also used for heart arrhythmias and especially. And then, you know, just going down the list of causes and identifying, you know, what evidence of those causes are in the data, and so how we can appropriately exclude them to be sure that it's unknown etiology. And then once we have that algorithm, we need to implement it as software and execute it against UF Health data, then randomly select a subset of those patients and do chart reviews. And we will read the clinical notes for those patients and see if the clinical notes indicate a cause we didn't detect through the structured data, or if it's true CKDu as adjudicated by our experts. And that'll give us, again, then the positive predictive value, recall sensitivity of the algorithm. You know, and then we really are hopefully nearing the stage where we can start onboarding a community and migrant health center and getting their electronic health record data, so that by the time the computable phenotype's ready, we can use it against their data and start looking at their patient populations and as well. Ultimately, you know, if we find CKDu and it's associated with certain agricultural operations or pesticides, then, you know, we hope to influence policy on how, you know, what safety precautions are put in place to protect the workers.